My name is Soleil Rowe, and I am a student in NURS 2500 Health and Illness 1, Section A02. And today I will be presenting my metacognition strategy elaboration, where I elaborate further on my concept maps I make with bullet points added. I chose the topic of speaking on the 4 leukemias, and I will be addressing the similarities and differences between the 4 leukemias. So leukemia is a broad term given to a group of diseases that affect the blood components, and specifically the bone marrow stem cells, which do create the platelets, the white blood cells, and the red blood cells, and I'll think a couple other things. So it can affect anyone at any age, and it is determined the stage of the blood forming stem cells. It determines what stage they become immature or they become infunctional. So acute leukemias are a lot more dramatic. They do have a faster onset of symptoms, whereas chronic leukemias do affect the mature white blood cells and they are infunctional. These chronic leukemias live in your blood a little bit longer and they actually can present as asymptomatic. So with chronic leukemias, you can live for a little bit longer before it ends up affecting your lifestyle. So lymphocytic leukemias affect the lymphoid stem cells or lymphocytes, specifically B cell origin. And B cells are a type of white blood cell that help your immune system fighting against viruses and pathogens entering the body. So myelogenous leukemia is different, and it affects the myeloid stem cells and myeloblasts. So these form the red blood cells and the white blood cells, so the blood cell components. I start by creating an analogy map that helps me summarize information about a disease process. The active study strategy I use lets me store my information into long-term memory by creating these little bullet points, and then I further elaborate on why they are relevant to the disease process. So I have important information, the pathophysiology, head-to-toe assessment priorities, anticipated assessment findings, expected lab values, which is an important one that I really use during our midterm, subjective and objective data, medications, treatments, nursing interventions, risk factors, which for leukemia is kind of empty, but and diagnosis. I do revisit a topic, so I do say it's stored in my long-term memory, but I do eventually revisit the concept maps before a quiz or an exam, so I can redo the information, re-go over it, make sure I don't have any gaps in where I don't understand or where I'm confused as to why a bullet point might be relevant in a disease process. And this really helps me build those internal connections between points that I've been taught, so why they are associated with leukemia. So as I mentioned, there are 4 types of leukemia. I will be starting with acute myelogenous leukemia, and I will refer to it as AML. So AML is very common in adults. It actually makes up 80% of adult leukemia. It is abrupt, dramatic, with a high mortality rate. So when a leukemia is acute, it works higher up on the blood-forming stem cell in the bone marrow. So that's how we know that it is it will cause a faster onset of symptoms like mentioned. So with AML, there's an uncontrolled proliferation and accumulation of immature myeloblasts. So these begin to crowd out and interfere with the other blood cells, actually causing a decrease in platelets, red blood cells, and white blood cells, because they are crowding out this bone marrow with all the healthy cells and they are taking up the room, and this actually does cause bone pain. So it's very similar to the other acute leukemia, acute lymphocytic leukemia, and that I will refer to it as ALL. So in ALL, this is the most common leukemia in children, and what it does is it accumulates these immature lymphoblasts, and they are usually B cell origin. So these lymphoblasts proliferate in the bone marrow, and they do fill just like the other acute leukemia. They fill out, they crowd out, and they do cause bone pain as well. So the only difference between the two, AML affects myeloid blast cells, so myeloblasts, And ALL affects lymphoblasts, and they are the B-cell origin ones. Chronic myelogenous leukemia, or CML, is the myeloblasts proliferate into their mature stage, but they are cancerous. So you have mature but infunctional neoplastic myeloblast cells. So chronic myelogenous leukemia does have a blastic phase and it has a chronic phase. So people will present in the chronic stage when they are asymptomatic, and the blastic phase is unfortunately when the myeloblasts have proliferated and filled up the bone marrow, causing bone pain, but they do spill out into the peripheral blood. So this does cause that taking over. Chronic lymphocytic leukemia, which is known as CLL, is common in adults, but it takes longer to formulate, just like the other chronic leukemia, CML. So there's a production of functionally inactive but mature B-cell origin lymphocytes, and these do invade the liver because the liver is filtering the blood components, and they invade the spleen because they go to the spleen to die. So because there's a great increasing number of them in the blood, and they do, since they are inactive but mature, they do die quicker, and so they are going to overwork the spleen and overwork the liver, and then you can get swelling of those organs, and that would be an anticipated assessment finding if someone was having like upper quadrant pain. The ER patient presents with bone pain, fatigue, malaise, and a fever. How do we know which type of leukemia to screen this patient for? So first we're going to complete a CBC, and we're going to complete it with a differential, which means you get to see more in depth on the white blood cell counts, because the CBC is just a general blood count of platelets, red blood cells, and white blood cells. So you can see what's going on inside that patient's blood. And acute leukemias will show pancytopenia, which is low red blood cells, low white blood cells, low platelets. And chronic leukemias will show anemia, but their white blood cells and platelets differ in values because it correlates with the progression of the leukemia, because chronic leukemias typically take longer to show symptoms, or you can even present as asymptomatic because of the hypercellular bone marrow process takes a bit longer because it works lower on the blood forming stem cells. So if a patient presented in the ER with those symptoms mentioned, you could ask if they have any bone or joint pain, decreased urine output, any family history of leukemia, recent infections, and onset of symptoms. A lot of these symptoms do share similarities with other diseases, so fever, fatigue, malaise, weight loss, shortness of breath. Those also could be symptoms of the flu, or symptoms of even COVID, or symptoms of a bad infection, maybe sepsis. But after finding the lab values from the CBC, a bone marrow aspiration could be performed to ensure you're on the right track with diagnosing a patient with possible leukemia. So the aspiration would show us a plethora of immature blast cells. So that's how we would know we're on the track to diagnosing a patient. Ways to treat leukemia can be chemotherapy, corticosteroids, or stem cell transplant. Now, chemotherapy uses radiation to kill leukemic cells, but also the body's healthy cells, and it damages the DNA and interrupts mitosis. Stem cell transplants are when you could take cells from a donor or actually take your own healthy cells, and they will hopefully produce non-cancerous cells and foster like a environment in your bone marrow to create new cells. So those are the two treatments. Both of them do have risks, as chemotherapy can put you at risk for secondary cancers or even an infection because your immune system is so weakened. And stem cell transplant, you can actually have graft versus host disease, and that is when donor cells that were placed in your body attack your own body's immune system and cells, and that's a very serious risk that I hope no one ever has to go through. So those would be drug therapy. To conclude my project, by elaborating on my concept maps, I'm not only understanding, but I'm explaining the pathophysiology behind a disease process. This helps me check my understanding. So if there's any gaps or any part where I can't explain the pathophysiology, I can go to my textbooks or I can ask my professor, and I can then kind of figure out where I'm not understanding. So for an example, because I usually don't read these maps out loud as I just did for my project, I'm going to use, for AML, an anticipated assessment finding is gout, and gout is the inflammation and accumulation of uric acid in a joint. So why would that be an anticipated assessment finding, you ask? So with my concept map, I see that I have it under as objective data, something I might find. So I have to ask myself, why would that be associated with AML? And that is because I then elaborate as I understand that because of the constant lysis of these immature myeloblasts, they actually release their cell contents into the blood. And this so happens to release uric acid into the blood, and accumulation of the uric acid in the blood will find the joints and create that type of swelling. So that is how I would elaborate further on the bullet points. To acknowledge the references I've been provided with by MedSurg Lewis textbook, NURS 2500 PowerPoints, and the lecture on leukemias. And with all of those, I am able to understand.